Thank you everyone for joining us for the webinar on management of early lung cancer, current and future. I would now like to hand it over to our program director, Dr. Satheesh CT, medical oncologist from Bangalore. Over to you, sir.
Yeah, good evening, everyone. Thanks, Kashish. Say today we are there deal with it we are there the new conference about virtual meeting on early lung cancer because we are having so many meetings. We used to have dealing with mainly advanced lung cancer. Just let me begin with our the center like a Spandana Oncology Center. It is a daycare center located in center of Bangalore. Like almost it is a 3.5 year old. Almost per year, per month, we are having infusion of around 100 to 120 infusion per month. And we know the situation how this COVID-19 is affected badly globally, even Indian also. We are also affected very badly like a couple of months. Slowly that India is picking up. Only thing is we are with this COVID is affected so many people, common people to even rich people and even like medical people. Like we lost so many our colleagues and even elderly and our supporting staff, nurse, all the thing only thing is like in this situation we are seeing almost even the COVID we are trying to live fighting with a new life with a wearing mask, all those things, social distancing, all those things. But only thing cancer is many people are because of lack of coming to hospital, all those things, lot of upstaging, 40% they are having the detrimental of outcome. What was a global data they say let us see that we supposed to don't if you are not the patient is your patient is not coming to your center, at least you can ask your colleague who are whichever the city nearby request your patient to come for a continuous at least on telemedicine and continues to be on follow, which are able to do some local testing, which are available methods are there. Please continues to take care of your patient, ask them to visit whichever you are not able to visit you, at least nearby your friends or anything. This is my sincere request. Today I'm there to see that one to avoid this contact not like treatment at least you are we are to with a new near life with wearing a mask, social distancing. I'll try to request you to continue to seek your treatment of your cancer patient. I request Kashish to play a short video regarding this. What is there let us watch a short video on this. Yeah, thank you, Kashish. With this realizing that what is please I request continues to ask your patient to visit and continue treatment of your cancer cancer patients. Let us start with a program for today regarding the early lung cancer. I request Dr. Poonam Patil. She is the senior most medical oncologist from Bangalore Manipal Hospital. She is chairing the today's session. I request Dr. Poonam Patil, Madam, to start the session. Madam, please.
Yeah, so welcome you all to today's evening scientific session. Today the topic is management of early lung cancer, current and future. As we all know that all modalities actually are gaining momentum in the last few years in treatment of cancer. And in cancer lung specifically, right from diagnostics to therapeutics, there is a leap that has happened. And earlier we used to treat only metastatic lung cancers with chemotherapy. Then came the locally advanced disease. Now even the early disease. With the onset of targeted therapy, the field of lung cancer has changed dramatically. So today we are going to discuss about management of early lung cancer. What is the current trend and what do we expect in future? So thanks Dr. Satheesh for having me here today. Let's start the session.
Let's start with our first speaker, Sarjana Dutt. She's going to talk about the molecular test in early lung cancer. Madam, please, you can start your session, madam.
Is my screen visible?
Yes, ma'am.
Okay, great. Thank you, Dr. Satheesh. And thank you, AstraZeneca, for inviting me to participate in today's conference. And good evening to all the speakers and the attendees. The last couple of decades have brought in a sea change in the manner in which we diagnose and treat patients of lung cancer. At one point of time, it was enough, and by and large, that is what used to be done, to just categorize lung cancer into histologically, histopathologically, into whether it was a squamous or an adeno, and whether it was a non-small cell lung cancer or a small cell. And today we are sitting at a place where it would be fair to say that the path of survival of non-small cell lung cancer patients is really driven by the biomarkers. So the diagnostics is dependent on the biomarkers, and side by side along with it, the treatment and the management of the patients is also driven by that. And you can clearly see that in this particular slide, which I have borrowed from the NCCN guidelines, that a significant number of targeted treatment modalities are now available for patients of lung cancer. And each one of these is really biomarker driven. So whether we talk about EGFR or ALK, which were one of the early biomarkers, and now we have more and more joining in. We have MET, we have NTRK, we have RET, so on and so forth. And since I'm a laboratorian, my talk really is going to carry the flavor of diagnostics. And this is how I would be proceeding. I would take a few moments to talk really about the tissue and the specimen, that what really is the tissue that one requires, how much is enough, what should be the nature of fixation, so on and so forth. What role really does histopathology or IHC play so far as lung cancer diagnostics is concerned? Which biomarkers to test and which technologies to use. I would also be spending a little bit of time in talking about the pitfalls that we sometimes encounter among these technologies and how to go about the troubleshooting. So first thing first, which histology to select? We know very clearly that it is adenocarcinoma, non-small cell cancer, which really needs to be tested for biomarkers. However, it is very clearly written that even for samples, even for specimens which are of mixed histology or poorly differentiated carcinoma, even if they carry any little bit of adenocarcinoma morphologically, it does make sense to go ahead and perform biomarker testing. And though it is written that for a pure SCC, EGFR, ALK, ROS need not be required. However, this does not hold good if the patient is young in age and a non-smoker. So for those patients, it makes sense to go ahead and do biomarker testing for them. Now, if at all histopathologically, morphologically, it is not feasible or not easy to diagnose whether we are dealing with an adenocarcinoma or an SCC. A limited IHC staining may be done, and in fact, just 2 IHC markers are really enough to help out using either TTF or napsin, which favors adenocarcinoma, and P40 or P63, which favors SCC. So choose any 2 markers from these panel, and that should be enough. However, if by morphology we can diagnose and we can know that yes, what really we are dealing with, then an IHC need not be performed and the specimen should be shared for biomarker, which should be spared for biomarker testing. The type of sample collection and the site. So the most accessible site should be tested. However, if we are dealing with a case which is metastatic in nature or a case which has been treated previously and has progressed on treatment, then it may be important to look at the newer lesions also. And in those cases, a rebiopsy as well should be considered. Which biopsy techniques? By and large, any and most standard biopsy techniques can be used. So a CT-guided needle core biopsy, a transbronchial biopsy, an endobronchial biopsy, or the EBUS TBNA. Any of these technologies can be used to retrieve the specimen for morphology, followed by the biomarker testing. Important here, it would be to stress that really, sometimes we get a query that really, how much specimen is required? What is the minimum amount of specimen or the minimum number of cells using which we can perform and adequately report out a testing? So here, it really, so if I had to answer in terms of how many number of cells, so typically for performing EGFR testing, we use about 100 to 150 tumor cells. However, it is equally important to know that what is the percentage of tumor in the core biopsy tissue that has been provided. If we find that the percentage of tumor in the tissue is less than 30%, then it does make a lot of sense to go ahead and do at least a manual microdissection for tumor cell enrichment, because all the technologies that are in use, they have their own analytical sensitivity. And it should not be that we end up reporting out a false negative because the percentage of tumor in the core biopsy itself was limiting. So doing a manual microdissection does really help. Cytology samples again can be used, pleural effusion can be used. However, the process remains that one should prepare a cell block out of it, do a morphological analysis, and then proceed with testing. So many a times, like we, especially in the arena of molecular biology testing, one hears this phrase, garbage in, garbage out. So again, here, tissue really is the issue. So it is important that we preserve the tissue in the best possible quality and best possible manner. So for biomarker testing in lung cancer, the tissue should be fixed in 10% neutral buffered formalin. This is the accepted fixative. Bowens fluid should not be used. Any other acidic fixatives should not be used as well. Many a times, apart from the molecular testing, one also needs to do fish studies. And there, it is important that the tissue that we have, it should not be stained with eosin. What happens in the pathology section is that here we are dealing with very small core biopsies And just as to ensure that we do not lose out on the tissue, they may sometimes be stained with eosin, but eosin has a very high autofluorescence of its own, and it interferes with fish studies. So this is something which should be taken care of. As I've already mentioned, that the quality and quantity both are key determinants. If there are multiple primaries, if feasible, then use all. Else use a technology which represents the tumor heterogeneity. So something like a plasma sample can be used. This is the list of, by and large, most of the laboratory biomarkers which are currently being used for non-small cell lung cancer and the methodologies used most often. This list is by no means exhaustive. It is just a representation of which are the most commonly tested. So, and again, this differs from organization to organization and hospital to hospital. There are certain hospitals and certain clinicians who prefer going the standalone testing method of testing one biomarker after the other, in which case it might be ARMS PCR followed by IHC, followed by FISH, and so on and so forth. Alternately, one can go ahead and use methodology such as NGS, which would give you a very, very comprehensive analysis of all the biomarkers that we are interested in testing. So far as EGFR is concerned, it is very well established that there is a higher incidence of this mutation seen in non-smokers and female patients, as also that there is a population bias. We know that the percentage, that the incidence rate of EGFR mutation in Caucasians is less, and then there is an increasing trend towards Asians and Orientals. This is data from last year from our own laboratory, and using ARMS PCR, we typically see a positivity rate of anywhere between 26 to about 32, 33%, which is similar to what has been reported from other labs in India. Using ddPCR, we see a higher percentage, and this may be because of a variety of reasons, and typically for ddPCR, we often get patients which are advanced cases, or patients which have either relapsed or become non-responsive to treatment. And that is the reason why you would see that there is a very high percentage of T790M that we see in these cases. ALK analysis may either be performed by IHC using the D5 F3 clone, which is FDA approved, or using FISH analysis. Both of these methods are FDA approved. By and large, the ALK positivity using IHC is in the range of about 7 to 8.5%. Using FISH, it remains slightly lower. Now that may be because the readout modality between the two technologies is different. Using FISH, until and unless we see a break apart signal in at least 15% cells, we do not call it positive. ROS analysis, again, we have antibody available, the D4, D6 clone on the Ventana platform. However, at this point of time, it is validated only for screening purposes. So any cases which show up as positive on IHC should be further tested using the FISH break apart probe.
Ma'am, 2 minutes left, ma'am.
Sure, I'll just hurry up. And this just typically shows what the most common patterns that we have seen. PDL1, again, multiple platforms and multiple antibody clones. However, thanks to the study sponsored by AstraZeneca, we now have a very clear clarity that using different clones also, we have a readout. So for use of pembrolizumab, if one is using 22C3 antibody, then anything above 1% means that the patient can be treated with pembrolizumab. However, if one is using sp263 antibody, then at least 50% cell staining should be there. MET gene amplification, there are two mutations which are important here. The exon 14 skipping mutation, which should be assayed by PCR or sequencing, and the gene amplification itself. Now, it is important that we should call it as amplified only if the ratio that we see of MET to the internal control, it should be more than 5. The ratio should be more than 5, and only then we should call it positive. And it is important to be cognizant of this because there is a very high level of polysomy that we observe for the chromosome 7 in lung cancer. So the differentiation between these two is important. RET gene rearrangement, again, important to stratify the patient for cabozantinib or selpercatinib treatment. And here what is important is that unlike most other split apart signals, here even if the signal diameter, it differs by 1 signal diameter, we call it positive. Mostly for fish, it has to be differed by 2. So this is important if someone is using this probe. So I would just want to wind up by saying that there are challenges and there are unmet needs when one goes ahead for biomarker testing, but there are a lot of new modalities also coming up. So if either in terms of the specimen that one has or in the quality of the specimen, if there is a limitation, so one can either increase the scope of the technology, use something like NGS or proprietary algorithms, or increase the scope of the sample that is available. So rather than depending only on the biopsy or the cytology, one can go ahead and use plasma samples. And again, NGS is one such modality which works both on tissue as well as a plasma. And using this in a short period of time with a limited amount of sample, one can answer the question of which biomarkers are available. And so far as lung cancer is concerned, the biopsy as well as the liquid biopsy, it goes really hand in hand. And the diagnostics and the biomarker assaying of the patient should not be limited just because a biopsy tissue is not available. Using ctDNA, using plasma sample, one can still go ahead and perform testing for all of these markers. So there are newer biomarkers, newer technologies, and newer guidelines. Diagnostics is certainly evolving, and so are we. Thank you so much, and I'm sorry for overshooting my time.
Thank you, madam, for excellently covering that molecular test in lung cancer. I think we'll have a couple of questions in the panel discussion. Just one thing I wanted to comment, is it this is well validated in the advanced lung cancer? It is recommended to do all the tests in the early lung cancer is my question. That's what this is the audience want to convey this message. What are the tests, molecular tests, so panel of tests is there. It is already approved, everything well established in advanced. Do you want to recommend to all the early lung cancer? That's what is the question.
At least EGFR certainly should be done for early lung cancer, because also in terms of the incidence rate, that is one biomarker which is of utmost importance because it is incidence rate wise the most highly seen positivity wise.
Thank you, madam. Thank you. I request Dr. Poonam Patil for the next introduce the next speaker, international speaker, that is Dr. Rosario. Madam, Dr. Poonam Patil to introduce the chief speaker for today's session, Professor Rosario.
Yes, so I welcome Dr. Rosario Garcia Campelo to speak on the next topic, newer paradigms in the management of resectable EGFR mutated early lung cancer. As you can see, Madam is the head of Oncology Clinical Research Program and Thoracic Tumors in Medical Oncology Unit in University Hospital. Welcome, Madam.
Hi, can you see my screen?
Yes, please.
Hi, good evening. First of all, I would like to thank the organizers for their kind invitation. It's a real pleasure. It's an honor to be with all of you. I wish we could see in person. I have been just once in India, and it was probably one of the best trips of my life. So let's see how things go in the near future. And also it's a great honor to talk about and to focus in one of the main topics of this difficult year. Today, I hope we will have a very fruitful meeting and overall a very interactive session, because we are focusing on these new paradigms in early stage non-small cell lung cancer population. We have good news after so many years. These are my disclosures. And let me start with a kind of reflection. It seems that in early stages, nothing has happened during the past years, but the truth is that there is a huge amount of effort in this setting. Today, we will just see a small piece of success, but again, a huge amount of effort during the last years to stay today here talking about this good news. We know that surgery is the standard of care, is the curative treatment for early stages non-small cell lung cancer, the vast majority. But despite the new technologies, despite the great advances in the thoracic field, the truth is that still many of our patients will relapse. Many of our early patients will die because of lung cancer. So probably one important message here is that there is still a huge room for improvement. This is where we are. And we know that for those stage 2 and stage 3A resected non-small cell lung cancer patients, adjuvant chemotherapy is the standard of care. We can discuss for stage 1B the benefit of adjuvant chemotherapy. For those considered resectable stage 3M2 disease, it depends on the center. For example, in my hospital, we tend to use neoadjuvant strategies followed by surgery. And for those unresectable N2 disease and stage 3B, you know that chemoradiotherapy plus immunotherapy is our standard of care. How relevant is the benefit we can offer with adjuvant chemotherapy? Again, we can define this benefit as modest. We can discuss it later, but for me, it's a modest benefit. We know that we can offer a 5-year survival benefit around 5%. We know that for those patients stage 2 and 3, the benefit is higher with hazard ratio of 0.3. We know that for stage 1B, the benefit is not so significant, 0.93. And for stage 1A, it can be detrimental with a hazard ratio of 1.4. Sorry, I don't know what is happening here. Okay, so what are the main recommendations from the most relevant international guidelines? Platinum-based adjuvant chemotherapy, and so far, no targeted agents were recommended in the adjuvant setting. But we know that our way to treat, our way to understand non-small cell lung cancer patients has completely changed, and EGFR mutations have been probably the very first example of personalized medicine in advanced non-small cell lung cancer. We have included color in our definition of non-small cell lung cancer patients. This is our standard of care in advanced non-small cell lung cancer patients. And the question, or the key question, is how we can translate this benefit and this idea, this appealing idea of personalized medicine to the early stages. Let's review some data we already have. This is one of the very first trials analyzing the role of EGFR tyrosine kinase inhibitors in resected stage 1B, 3A non-small cell lung cancer patients based on EGFR positivity by immunohistochemistry and FIS. The disease-free survival, the primary endpoint for the trial, for the global population was a negative endpoint. And it was a pre-planned analysis to do this disease-free survival analysis in the subgroup of patients with EGFR mutations. You can see it seems that there is a benefit, but because of the statistical design of the trial, this cannot be considered as a positive trial. So Radiant, an old-fashioned trial in this new era of targeted therapies in early setting, is a negative trial. The SELECT trial is a different trial. It's a single-arm phase 2, and basically 100 patients harboring EGFR mutated stage 1A, 3A resected patients were included. And you can see the disease-free survival, the 2-year disease-free survival was 88% and was superior to the historical control group that was the main endpoint of this trial. And you can see how this benefit is really, really relevant in patients with stage 3A disease. And this effect is going to be seen in many of the trials we are going to review. This is the adjuvant sitting on 1104 trial is probably the first trial that has shown overall survival data in this specific scenario. Stage 2, 3A EGFR mutated, resected non-small cell lung cancer, adjuvant gefitinib 2 years versus conventional chemotherapy. Disease-free survival was significantly higher for patients receiving gefitinib with a median gain of around 10 months. But the update of this trial that has been presented this year at ASCO showed no significant differences in terms of overall survival, and this benefit in disease-free survival seems to be lower when the trial has a longer follow-up. Well, another trial, a very interesting trial, is the IBAN trial. This is an ASEAN trial that also, but specifically just only in 3A disease, resected 3A EGFR mutant population, has compared 2 years of adjuvant erlotinib versus conventional chemotherapy. Disease-free survival, you can see the curves. It's really relevant, the benefit favoring the use of erlotinib, and the data for overall survival is still immature. But here is a clear signal of benefit for this population, stage 3A EGFR mutated who receive adjuvant erlotinib. We also have a meta-analysis, and here you have a very recently published meta-analysis showing how for disease-free survival, it seems that the adjuvant TKI compared to placebo is positive, and also adjuvant TKI compared to adjuvant chemotherapy offers a significant benefit in terms of disease-free survival. We are not talking about overall survival. Well, let's move forward to the DAURA. The DAURA trial, the very first trial using osimertinib in a phase 3 in this early scenario. You already know the design of the trial, stage 1B, 2, 3A. Patients are allocated to osimertinib versus placebo during 3 years. The primary endpoint of this trial was disease-free survival assessed by investigator in stage 2 to 3A, and secondary endpoints, disease-free survival in the global population, and landmark disease-free survival at 2, 3, 4, 5 years, overall survival, safety, quality of life, and pharmacokinetics. It's important to remember that this study was unblinded early due to efficacy. But the time the study was unblinded, the median or the minimum follow-up for patients, for all patients included in the trial, was 1 year. Here you have the main inclusion and exclusion criteria. Stage 1B, 3A, completely resected. Only patients harboring exon 19 or 21 mutation. Adjuvant chemotherapy was allowed, but it was not mandatory. We can discuss later the relevance of this criteria. And no prior or post-operative radiotherapy was allowed, and no patients with segmentectomies or wedge resections were allowed in the trial. Here you have the main patient's characteristics. 64% of patients were ASEAN. Most of the patients have stage 2, 3A, and 55% of patients receive adjuvant chemotherapy in the trial. And this is the main endpoint of the trial, and I think these curves are really impressive. They separate very early, clearly, and it's very visual, the difference, with a hazard ratio, I would say amazing. 0.17, the median disease-free survival was not reached in osimertinib. In the group of patients who received osimertinib, it was 20 months for those receiving placebo. 2-year disease-free survival, 90% for those receiving osimertinib, 44% for those receiving placebo. And here you have the disease-free survival in the global population. Hazard ratio, the curves are still very clear. They separate from the very beginning. Hazard ratio with the global population, 0.21, and again, a benefit, very huge benefit at 2-year disease-free survival in these curves. Talking about the subgroups, it seems that every single subgroup is getting benefit from adjuvant osimertinib. This also, if we see the difference between exon 19 and exon 21, it seems that the benefit is higher for those exon 19 patients. This is something that also has been seen in the other trials I have already commented, and we also have seen this effect in advanced disease. So let's look at the hazard ratio according to the states and the curves. Clearly, stage 2 and stage 3A, these are the patients who are getting the strongest benefit from the adjuvant osimertinib, but still stage 1B disease is positive with a hazard ratio of 0.5. It's early to talk about the overall survival, and probably this is one of the points we are going to discuss during this presentation. Well, let's talk about safety. For me, in my practice, osimertinib it has many advantages, but one of the most important advantages is the safety profile. I think it's a safe drug, and when you see the safety from the trial, adverse events leading to discontinuation 11 versus 4, adverse events leading to dose reduction 7 versus 1, and most of the adverse events are grade 1 to 2. Basically diarrhea, and we can discuss also the impact. And for me, it's very important to see the quality of life data from this trial. But this is what we see, grade 1 to 2, basically diarrhea, basically skin toxicity, and we shouldn't forget the QT prolongation that was reported in 7% of patients receiving osimertinib. Well, this is the big presentation. We have a New England. Let's talk about the data that were presented in ESMO, focus on CNS disease. We already know that CNS is a problem always when we talk about lung cancer. We know that even in these early stages, the CNS is a common site of metastasis, and we know that drugs like osimertinib can penetrate. They are really good penetrating the blood-brain barrier, and also have a very nice activity in patients harboring brain metastasis. Let's try to analyze this issue of brain mets, and let's try to do it trying to answering important questions. Prevention of brain mets in patients treated with curative intent. This is an unmet need. Easy answer, yes. We know that patients, again, overall those with N2 and 3 disease, adenocarcinoma patients, have a great risk of developing brain metastasis. I am just talking about the general population, not EGFR mutated. And we know that chemotherapy is not very good trying to prevent brain mets. So unmet need, yes. Is the magnitude relevant? Well, it seems that the magnitude of brain mets is lower than in advanced disease. And it seems that when we talk about EGFR and we compare to wild type population, it's pretty much the same situation, okay? And well, we have seen the numbers, but how relevant is brain mets or prevention of brain mets from a clinical point of view? All of us who treat lung cancer know that patients who develop brain metastasis have poor outcomes, have poor quality of life. Treating patients harboring brain metastases is expensive. And we know that these new compounds, this new generation of EGFR tyrosine kinase inhibitors are really active at the brain level. So let's see the data. Let's see the data that were presented at ESMO. Let's analyze the type of disease recurrence. And first, let's see the numbers in terms of global recurrence. For osimertinib arm, 11% of patients develop progression compared to recurrence, compared to 46% of patients in the placebo arm. Another important aspect, of those patients who receive osimertinib and develop disease recurrence, most of the recurrence happen at the local level, while in those in the placebo arm, most of the recurrence happen at distant level. Let's focus in the brain. 1% in patients receiving osimertinib compared to 10% in patients receiving placebo. And again, very important disease-free survival curve, CNS disease-free survival in the overall population. It's true, we need to follow this trial with a longer follow-up, but again, we are talking about a hazard ratio of 0.18, and it wasn't reached the median CNS disease-free survival for osimertinib compared to 48.2 months. Another aspect, the probability of CNS and non-CNS recurrence. And I think this is important. The estimated probability of observing CNS recurrence at 18 months was less than 1% for osimertinib compared to 9% with placebo. Well, we have a nice trial, a very clear design, very clear results. How can we compare this trial with other trials? I strongly recommend you this review. It's a very nice review that has been done by Spanish colleagues. And the truth is that if we compare with the biggest phase 3 trial, the CETON 1104 trial, the hazard ratio, the disease-free survival hazard ratio is clearly better when we see the DAURA results. And in fact, FDA has approved osimertinib very recently as adjuvant therapy for non-small cell lung cancer harboring EGFR mutations, and the ENCCN guidelines include osimertinib as a recommendation for those patients with stage 1B, 2, 3 disease harboring EGFR mutations that have been completely resected disease. Well, I truly believe this is a nice trial. I truly believe this is probably one of the most important trials of the year. But also, I truly believe that this trial, as every single trial, has lights and shadows. So let's analyze some of these lights and shadows. The great debate, the endpoint, OS versus disease-free survival. OS is the holy grail, and probably is the holy grail when we talk about the curative scenario. Disease-free survival is the endpoint you use when you want the results earlier. It's easier to achieve. The key question is sufficient? Probably it's helpful overall with the magnitude of benefit we have seen in this trial, has a ratio of 0.17. But we shouldn't forget is a surrogate. I wonder, and for me, this is something that I truly believe, is that osimertinib works in the adjuvant setting, but it's not working for every single patient. Probably we are over-treating a lot of patients. So I think that probably we should select much better the patients we are treating with osimertinib, and I insist that ctDNA and minimal residual disease could be clear elements for decision in this patient population. More shadows or more lights, it depends on how we want to see it. Basal PET CT, it was not mandatory. So we know that this can get some kind of confounder. Another aspect, brain CT or brain MRI. We don't know exactly how many patients have brain CT, how many patients have brain MRI, and it's important to understand how the trial goes, and also it's important to implement in our daily clinical practice. How easy, how difficult is to do a brain CT or a brain MRI. And I think osimertinib at the time of progression should be part of the design. The issue of adjuvant chemotherapy. Should we do it? Should we don't do it? The fact is that the benefit of adjuvant osimertinib doesn't seem to be related to the use of adjuvant chemotherapy, but the truth again is that tomorrow in our practice, the trial is not answering us a key question. Do patients harboring EGFR mutated, resected EGFR mutated population, do they need adjuvant chemotherapy? Should we do a kind of de-escalation process? What are we going to do tomorrow? Adjuvant, chemo, or not? So again, many questions. What happens after progression? This is particularly important. How patients are going on after progression? They receive osimertinib, how the outcomes are, and the issue of duration of treatment. Do we need 3 years of treatment? We have seen the previous trial, basically they used 2 years, and the results were not so strong. So maybe 3 years is the optimal duration of the treatment, but the truth is that we really don't know. Let's move forward and let's talk just a little bit about neoadjuvant therapy. For me, the neoadjuvant therapy is the best scenario to test many hypotheses. Frontline attack of micrometastasis, better compliance and tolerability, potential improvement of downstaging, potential increase of pathological response, and the most important, you can study the biology of the disease and you can have an early readout of efficacy. I love the neoadjuvant scenario. And we know that from previous meta-analysis that the benefit of adjuvant chemotherapy is quite similar to the benefit of neoadjuvant chemotherapy. What do we have in the neoadjuvant scenario when we talk about EGFR tyrosine kinase inhibitors and EGFR mutated population? We have few trials, small trials, and not consistent results. This is the truth. We have different trials with short courses of neoadjuvant EGFR tyrosine kinase inhibitors, and the results are not so impressive as one could expect. The response rate around 40 to 60. This is not so high for an EGFR mutated patient. The major pathological response is low. So the truth is that we don't know if this is the strategy, but we are trying to really get good answers for the role of neoadjuvant tyrosine kinase inhibitors in EGFR mutant population. And we have wonderful trials in the adjuvant setting, and we have wonderful trials in the neoadjuvant setting. For me, the DAURA is probably one of the best trials at the moment, stage 2 CD, comparing neoadjuvant chemotherapy plus OC, or neoadjuvant osimertinib. Let's see what we get. Another aspect I am almost ready to finish, the role of EGFR tyrosine kinase inhibitors in unresectable EGFR mutant population. We have the Pacific trial, and the numbers of EGFR mutated patients were really small, but it seems that it's not the best way to treat these patients, offering immunotherapy after concurrent chemoradiotherapy. And the fact is that many trials that are ongoing today basically don't exclude EGFR mutant from their recruitment. For me, I don't know if this is the way to move forward in this unresectable EGFR mutant population. For me, the very best to move forward is trials like this one, the LAURA trial. The LAURA trial is testing in patients with unresectable stage 3 disease, chemoradiotherapy, and then they are randomized to osimertinib versus placebo, patients harboring EGFR mutations. So let me finish with some very simple messages. I think the DAURA trial is a game changer, is a winner. Still, I think we need to follow the trial, the results of the trial. We need to look to overall survival data, to quality of life data. But as I mentioned, the disease-free survival is probably one of the best data we have this year. We have new trials in the neoadjuvant setting in unresectable scenario, the LAURA trial. And the main message I would like to send today is that personalized medicine in early stage lung cancer is here to stay after many years trying to make this real. It has been mentioned that COVID-19 and this year has been very difficult for the whole society, for all of us. For cancer patients has been really a very difficult year. And for us as professionals, I think COVID-19 has stolen an essential part of our profession. This is a drawing my daughter made of myself in April 2020. I am not like that. I always try to be positive. I always try to do the best for my patients. I want to be doing the best for my patients because I think they deserve it. So I think this is the really way to move forward. Good science, good trials, always thinking in patients. This is where I live, northwest of Spain, and I wish and you are more than welcome to visit us whenever this pandemic ends. Thank you so much for your kind attention.
Covering the excellent talk, we heard about a lot of things about early lung cancer, a lot about that EGFR mutant lung cancer. Your extensive whatever doubts we had, the treat with TK, which TK you have to treat, and how long, all those things you are covered extensively. And we'll have a lot of questions are there in our audience, and even how to change the practice and the thing. We made changes in our day-to-day practice, and let's have some practical difficulties, queries, all those things. We'll have a case-to-basis panel discussion. I request, thank you, madam. I request next that session, Dr. Amit, the senior most medical oncologist from Manipal Hospital, Bangalore.
So your voice is very faint, sir. So we're not able to hear you, sir.
Can I request Dr. Amit Rauthan, sir? He is a senior medical oncologist from Manipal Hospital, Bangalore. To start a panel discussion, we're having a lot of difficulty, a lot of discussion has to happen regarding the early lung cancer. I request Dr. Amit Rauthan, sir, to start on the panel discussion. I request the panelist for this today's session is Dr. Krishna Prasad. He's a senior most medical oncologist from Mangalore, and Dr. Narayan Kuti Warrior from Calicut, and Dr. Vishwesharaya is a radiation oncologist from Mysore. Dr. Satnarayana is from Mysore, and I request Dr. Datta and Professor Rosario to be in panel discussion. I request Dr. Amit Rauthan, sir, to start on panel discussion. Go to Dr. Amit Rauthan.
Thank you, Dr. Satheesh. Thank you, AstraZeneca, for giving me this opportunity. We've heard a very wonderful talk, two wonderful lectures, and it was really eye-opener talk to hear about all the early advances in the early stage lung cancer. I think what I want to do is we'll talk about how we could use this in our practice. They've named this as a Pentagon panel, and I was kind of curious, why did they name it as a Pentagon panel? So what they said was they have all the 5 integral parts of treatment of lung cancer. We have today on the panel a pulmonologist, we have molecular biologist, we have a surgical oncologist, we have a medical oncologist, and we have the radiation oncologist. And you can't manage lung cancer without any of these. It's very important to have all of us working together for trying to get the best management out for our patients. So I think I welcome all my panelists. Dr. Somshekhar also is here. Yeah. So all of us are here. Okay. Before I start, I promised myself I will not make some cliche statements, but I will make one because the most cliche statement we hear is in every morning when you wake up and you open the newspaper and you see the news on the internet and you hear the news, there's a new FDA approval of a new drug in oncology. And I promised myself we won't be talking this way and I won't make this statement, but I have to make it because just a few days back, I opened the news and FDA has approved osimertinib after the ADAURA trial as first-line therapy. So there's no way we can ignore this. So clearly now we have FDA approval for this. Okay, so we've seen the data sets and we have seen how the survival of lung cancer goes down with stage. I think we can't talk about management of lung cancer if we don't detect it, if we don't catch it. So let me start with Dr. Satyanarayan, who's our pulmonologist. Sir, what do you think? How do patients of lung cancer present to you in your pulmonology practice? And what percentage of various stages do you see in your practice?
Thank you. Privileged to be part of this August panel. The most common scenario we see is that in our practice, we find patients coming in stage 3, stage 4, more often than not. And that brings us to the question, how are the robust screening measures, in the community? And there are many challenges. Fortunately, say about 20% of all patients with lung cancer, we do find 1 and 2 coming in occasionally, sometimes almost as an incidentaloma picked up and patients counseled, and then that is happier thing to have those tumors resected. So that is the snapshot of the practice. The aim from now on is to kind of identify the high risk population. We have narrowband imaging technique, we have low dose CT scanners, we have the risk assessment tools, and we would like to catch them early.
Right, right. Well said, Dr. Satyanarayan. So you are always very proactive, and we know that. And as you are proactive, you caught my question early, and you answered my next question, which I was going to ask you exactly how, as a pulmonologist, you can help us with early detection of lung cancer. And you have answered this to us. We keep discussing so much of early stage lung cancer, but unfortunately, if we don't catch them early, we're not going to get them into all these kind of advanced treatment options. I kind of would like to see our medical oncology colleagues also. Is it the same kind of a practice you see, Dr. Krishna Prasad in Bangalore? Even you are seeing all your patients, most of your patients in late stage like we do.
Yeah, Amit, thanks for having me. I think the percentage of stage 1 and 2, in fact, any operable lung cancer is less than 10% in my practice here. So most of our patients are stage 4. In terms of percentage, maybe 75 to 80% are stage 4, 10 to 15% stage 3, and the remaining stage 1 and 2.
Right, right. Dr. Rosario, how are you increasing your early stage patient detection in your country, in Spain, and how is in your practice?
That's the key question nowadays, I think. We have a lot of questions going on in lung cancer, but the screening programs and how can we improve the rate of detection of early stages is one of the main issues. We don't have national screening programs. We are trying to do some kind of pivotal programs in the country, but unfortunately it's not, today is not a reality. We are working very hard with and very closely to the primary physicians. We are trying to give education and to let them know that these things are happening in the field of lung cancer, so we can get more patients coming to the clinic, to the pulmonologist clinic, trying to get those patients diagnosed earlier. And this is very important also when we talk about never smokers. I usually focus my attention when I go to these educational programs, because most physicians who are not involved in lung cancer care forget the fact that never smokers can get lung cancer. They can also be early stages, and now we are talking about EGFR mutant population, and basically these patients are never smokers. So this is also important to be remembered. In my practice, I would say that around 20% are stage 1 and 2. Most of them are stage 4, and stage 3 is around only 15%. We are very surgical center. We do a lot of surgery because we have this program of minimal invasive thoracic surgery. So many people from other areas come to the hospital, so we are very active in the early stage.
Right, right. I think that's the way to go forward. And Dr. Satyanarayan is the chief pulmonologist at our center, and I would kind of like his inputs on how can we set up a sort of a screening program at our center. What do you think? We should start off with low-dose CT. Is that the way to go further, or what do we do? How do we take it further?
We are looking at the data of people who have come in with a different medical issue, had an incidental pickup, and then they were counseled adequately, and then tissue diagnosis was obtained. And so the issue of annual health checkups that we are used to in our country, that should be one of the platform. Second, when you look at low-dose CT, the Japanese data, and the later on the UK and the Australian data, it does matter that high risk individuals selectively based on the risk assessment tools would have to undergo or should undergo low-dose annual CT to track and follow up. I think these are two things that will increase the detection of early lung cancer that are in stage 1 and 2.
Right. Thank you for those inputs. I think we should all work on this, so we will be catching our patients earlier. Okay, so let's go to if we kind of catch them early and we stage them, what's our line of management? Early stage disease, we're talking of stage 1, 2, and 3As. Dr. Somshekhar, I will start with you as a surgical oncologist. It's straightforward surgery, I know for you, but I would also like to get your inputs on when you think of surgery, what type of surgeries are you thinking of? I selectively kind of think of, because this trial, DAURA, had patients who had only lobectomy. They did not have other kind of surgeries. There was no wedge resections. They were all lobectomies, which are very, very kind of only very selected type of surgeries. And we also don't have the information of who had robotic surgeries, who had open surgeries. Even that information as of now is not out. So Dr. Somshekhar, your inputs on this?
Amit, there are two things. Number one, you asked about, what is the incidence of things of lung. I'll add you, it bases on two things before I jump out to this particular question you asked. Number one, the center where you practice and how robust your pulmonology department and what is the program you have. I will let you know that, we had only multiple physicians and non-intervention pulmonology before at our center, which is a regional cancer center. And I used to do about 18 to 22 watts lung lobectomy only. That is because most of them would actually come up in advanced state for us with tubercular therapy given. But when we have a robust intervention pulmonology department, they're more proactive. They join hands with you. And now suddenly about 30 to 38, 42 watts robotic lung lobectomy I'm doing. Second thing is, before we set up a robotic watts lobectomy, about 11 years before, our incidence was low. Now that across the state and region, people know we are doing a robotic watts, they get centered up. So now we can become quite a high volume. So that's why it is most important. The most important way to pick up early is actually not the oncology department, but an excellent pulmonology department, because they are the one who are vigilant. They refuse to start any TB medicine without a proof, and they pick up early. Having said this, now if you have a presumed early lung disease, it's very important to understand that what we presume early stage 1, 2, because up to 3A, they're surgically amenable, and 3A is a very gray zone. I'll let you know why. The most important thing is you prove that it is, lung cancer. So we usually have, if they're centrally placed and you have an intervention pulmonary, we try to do a EBUS radial biopsy and do it. If it is fairly situated, then we do CT-guided core. So the most important workup after that is an imaging, and contrast enhanced CT scan is the most important imaging, which would cover liver, adrenal gland at least, and the lower neck. Then we have either a EBUS guided core or a CT guided core, which would clinch the diagnosis. Having said that, the most whole important gray area is analyzing the mediastinal disease. Because we all know the hilar disease is an N1. The moment you are at N2, we are jumping to 3A beyond, 3B. So what we would do is, if you have a presumed stage 1, AB, 2A, 2B, then we would straight forward, go ahead with surgery. Even though PET CT scan in Indian setup for lung is a gray area, because most of the people have some mediastinal uptake, which would unnecessarily clinically upstage and deny a curative surgery, because PET mediastinal disease is not alone. So what I normally do is, if I have a N2 station, low, subcarinal, low paratracheal, paratracheal or aortopulmonary windows, I always take help of my intervention radiologist to analyze them, because they could be negative and I can still go ahead with a radical, robotic lung lobectomy. If I have before I had a intervention pulmonology, any mediastinal disease, I used to always do a mediastinoscopy. Now the mediastinoscopy about 80, 90 a year has come down to hardly less than 10 for me. So the most important is core biopsy, contrast enhanced CT scan, mediastinal disease assessment, and mediastinal node assessment either by a mediastinoscopy or a EBUS, and then truly knowing, is it stage 1, A, B, 2A, 2B, straight away they are candidate for surgery. We know very clear by multiple randomized trial, a radical lobectomy in a properly performed patient with R0 is equivalent to a pneumonectomy. Gone are the days of pneumonectomy. So now we do radical lung lobectomy, most of them. Unless there is a different reason, where sleeve resection cannot be done, then only we do pneumonectomy. Now, second thing is segmentectomy or subsegmentectomy is not accepted as a level 1 evidence for locoregional control. So the minimum surgery for lung malignancy is radical lung lobectomy with mediastinal lymphadenectomy, encompassing all N1 station, at least 2 N2 stations. And now most of the centers like ours perform VATS. You can have a thoracoscopic VATS guided or a robotic VATS. In our hospital, 100% is robotic VATS. So they are like a 48 hours day surgery and morbidity is low. The gray area is 3A. 3A, I would do a mediastinoscopy or a EBUS. Then I would assess it as a low burden or a high burden. Then I look at the histology and then the performance status of the patient. They are the only patient, after we discuss in multidisciplinary tumor board, I may selectively take for a surgery, or I may give a neoadjuvant treatment and not closing an option of curative lung resection later.
Right. I think an excellent overview. Dr. Somshekhar has given us the whole details about how we choose it. And I can tell you, I work with Dr. Somshekhar as I'm the medical oncologist and in the same center where he does it. And we know the difference and we know the amount of surgeries he's doing in this field with the robotic lobectomies. I think we have seen the difference over years, and we have seen how our lung cancer data has changed once we have moved to this kind of a proper staging and treating. So I kind of think we know that we moved away from mediastinopy to EBUS biopsies after Dr. Sathyanarayan started pushing for it much more. And we've seen the difference it makes in kind of getting a proper staging for your patients. After this adjuvant therapy, Dr. Narayan Koti Warrior, I would like to come to you in this group of patients. If you have these 2-3 stages, what is your choice as of now currently?
Yeah, thank you, Dr. Amit. As a policy, our hospital, we go by paclitaxel carboplatin, or in case of adenocarcinomas, we generally prefer pemetrexed plus carboplatin. Though the data is more for cisplatin plus vinorelbine, the usage of our vinorelbine is very, very low. And generally for all the squamous cell carcinomas, we go with the pacli plus carbo combination. And for all adenocarcinomas, we prefer pemetrexed and carboplatin.
Right. Dr. Warrior, do you treat your 1Bs with adjuvant chemo? The 1Bs selectively, I'm asking?
Yeah, I mean, yeah, the 1B certainly. So in fact, in all my talks, I generally, those days, the adjuvant chemotherapy was a very questionable thing. And then I generally put a slide that stage 1A, except stage 1A, all stages require chemotherapy. and then I'll tell what percentage of stage 1A belongs to the total group. It will be less than 1%. So please send all lung cancer patients to us. That was our those days we used to do that. And now this staging is much more accurate and stage 1. And so we generally give chemotherapy from stage 1B onwards.
Right. I agree with you fully. This is the way we practice also. Dr. Rosario, your thoughts on the adjuvant chemos you use and the 1B especially?
Yeah, I completely agree. From a standard point of view, in our clinic, we do adjuvant chemotherapy, usually with cisplatin plus vinorelbine in stage 2 and 3. We have many DAS with stage 1B, and we discuss case by case with the patients. I have to tell you, we have skipped the adjuvant radiotherapy in N2 disease after the lung-ARC trial that was presented. We used to do a lot of post-radiotherapy overall in those N2 disease that were found in the operating room or were after neoadjuvant therapy. But today we don't do more adjuvant radiotherapy. But we have a lot of trials today in the earlier scenarios. So most of the trials are testing the role of immunotherapy and immunotherapy combinations in very early stages. So we have this standard of care, and then we have moved to a lot of clinical trials with these trials of window of opportunity, testing different options. So this is basically what we do. Oh, so that's sorry about that. I didn't know that.
No, I think so the NADIM study was very, very striking. The stage 3A immunotherapy plus carboplatin having a CR rate of 60% was amazing to see the NADIM study this time, which really caught us by surprise. I think going the new adjuvant way is going to change the tide for some of these patients with lung cancer. But sure, I would still say not the EGFR mutant population, absolutely.
Absolutely.
Dr. Vishweshwara, I wanted to ask your thoughts. Which patients do you do post-operative radiation after surgery? And what are your thoughts on the lung-ARC study after it's come out this year? Have you changed practice?
Sir, you'll have to unmute your mic, sir.
Sort of, I'm a person who don't greatly believe in adjuvant radiation after curative surgery. That means I always believe there is an error in judgment of staging with me. Because it is something like this, after an adequate surgery and mediastinal, adjuvant radiation would have a lot of morbidity. But having said that, we don't live in an ideal world. We do end up with, unfortunately, understaging and doing it. Now, I would never exit a thorax in VATS without a negative bronchial margin. It would be disaster to have a positive margin at the pleura, chest wall, or the bronchus. That is non-excusable and it's almost non-curable. The condition where I would request help of my radiation oncologist would be, I presumed I had, totally analyzed the mediastinum as N1, but then it became N2 for me. So I would use radiation that is N2 station or positive.
Yes. Because that is the basis for that's what I'm telling. Initially, PORT was used in earlier stages. It was detrimental because of the techniques used and things like that. Now we are more accurate, as you said. The surgical techniques are better, and we are definitely improving our resection rates, R0 rates. So as Dr. Somsekhar said, if there is N2 positive microscopically, then only would add mediastinal radiation. And that is the right way to go. But not all patients need not undergo mediastinal radiation. If there are only positive nodes are positive after the histopathological examination, we can add adjuvant radiation to prevent mediastinal disease, etc.
But Dr. Vishweshwara, in the lung-ARC study, it was a completely negative, even for this group, for the N2 group, the lung-ARC study showing the no benefit of radiation.
I feel personally we have had 2-3 patients here where when the mediastinum is negative, I feel personally, as we have discussed earlier, mediastinal radiation adds to morbidity.
Right. So I think all of us have sort of got to, this is the standard of care we live in as of now. So now we move on to what we would do now, considering the new approach we have seen. Dr. Krishna Prasad, do you test EGFR mutation for lung cancer early stage patients? And if you do, when?
Yeah, all our patients, like I said, is very few in number, but anybody who undergoes resection, operable lung cancer, we do test for EGFR.
Right. And do you test for EGFR or do you test for everything in one go for these group of patients who have been operated?
We test EGFR, ALK, and ROS.
Right. Okay. Dr. Sarjana, I wanted to ask you, what do you think? We should go off to, when we have a good sample, nice one, should we just go off to NGS testing and get the extra information also?
I would really believe so, because there is so much more wealth of data that comes across using NGS. And over the years, I mean, in India, especially for Indian patients, pricing was always a constraint. But the costing for NGS has really come down quite significantly. So I would really think that yes, there is value to it, because even for these early stage patients, it does provide a very comprehensive baseline data that then one can build upon. So though in these cases really the specimen itself is not limiting, but the baseline data that one can get across using NGS, so that's something which really works well.
Right. Dr. Rosario, in your practice, so in early stage, if you do the surgery, do you send out an NGS for everyone?
No. When we have the DAURA trial open, we only used to do EGFR in-house. Now we have another trial, Adjuvant trial with an alt-tyrosine kinase inhibitor, so we move to do EGFR and ALK. And now we have those trials, neoadjuvant trials with immunotherapy. Most of them require those patients EGFR negative, ALK negative, ROS negative, and PD-L1 tested. So we basically do the 4 or 5 biomarkers we do have in practice in the earlier scenario, but because of the trials, not because of our clinical practice. So since we screen most of the patients to be included in the trials, we have this battery from the very beginning. But I think today EGFR is going to be mandatory.
No, we do the EGFR, ALK, ROS, and the PDL1, and then if it's negative, then we send out the NGS. But even I keep thinking sometimes maybe we have tissue, we should just get all the information at one go and then see how to take it later.
You can do it perfect.
Right. So coming to the last part of it is the ADAURA data. Dr. Rosario has given us excellent analysis of everything in ADAURA. Dr. Narayan Katiwariya, are you convinced? Are you convinced to use it for your?
Definitely. Even when the trial was, the interim results were out, we were very skeptical whether it is a push by the company or the pharmaceuticals. But finally, the analysis is very, very impressive with almost double the DFS which compared to the placebo group. So it is something which is very, very acceptable, and it's a definitely a practice changing study, and the results are convinced right now.
Right. Dr. Krishna Prasad, are you thinking of waiting for OS data? So I will be a kind of I will comment on it, saying that we had seen Radiant also, we had seen the Adjuvant also, sorry, the CTONG showing nice PFS benefit, at least to some extent till the drug was given. And when the drug was stopped, the curves dropped down. And then you had the nice banana curve where everything again goes down. And this follow-up here is, you're going to stop the drug at 3 years. Do you think the curve will fall? Or do you think you want to wait for OS data?
No, I will not wait for OS data. And I think the curve will fall, but I don't think the curve will fall that much significantly to, have a meaningful fall in the overall survival. I think there will be significant overall survival benefit. And I think, how do we otherwise look at it? The other option is not to give it and see whether giving it at the time of relapse will probably give the same OS. But practically speaking, no patient would want that, isn't it? It is always better to have a DFS. You don't want to live with the disease. So I think the chances are, yes, the OS will fall down, but it won't fall that significantly enough to say, I think it will not be significant. it will ultimately be significant, I think.
Amit, one more thing.
Yes,
Amit,
yes,
let me add one more thing. The previous speaker has very clearly mentioned about the delay in the CNS events, which is a very, very attractive thing. And if you look at the other similar trials, what you have said is correct. The overall survival, when it comes to the overall survival, all the other previous trials were not very impressive. So with the DFS data alone, should we or are we justified in interpreting these results like this? But definitely one of the main failure site is CNS. And if you can delay the CNS relapse, it is something which is a great achievable thing.
No, I think both of you have brought out excellent points, Dr. Krishna Prasad and Dr. Warrior. Both of you have clearly said that the amount of benefit, we have never seen these kind of hazards. When you start seeing hazards of 0.17, it is stunning to see that curves. And clearly, I think a big impact will come from the CNS protection which you're talking about. And I'm sure I would be surprised if we don't get an OS benefit out of this. It would be very, very surprising if with this kind of a PFS hazard, we don't get an OS. So I think this is practice changing for all of us. Dr. Rosario, but would you want to do it to your 1As or 1Bs also, or you leave it for 2 and 3s?
I think that with the data I have seen, I would prefer to do it in stage 2 and 3A. The main issue I have, because I truly believe in the benefit, and I completely agree with your previous comment, this hazard ratio is amazing. Probably it's going to be within the time not so significant, but I think it's amazing. The main issue I have is what to do with the adjuvant chemotherapy. And I really don't know, because looking at the data, it seems that even in stage 3A patients, they do well without adjuvant chemotherapy and with adjuvant osimertinib. But this is the biggest concern I have. What are we going to do with the adjuvant chemotherapy? I would like to know your opinion also, because for me, the role of osimertinib, adjuvant osimertinib, is quite clear. But what about the chemo?
So as of now, I would be very reluctant to leave the chemo. So
Okay.
I would say.
Me too.
I understand we keep thinking about that, but I look at it this way: the chemo is, especially in adenos, we are talking of pemetrexed carbo is what we use. We usually don't use vinorelbine, and that's perfectly a good, safe drug to use with not too much toxicity. So I'm very comfortable with that 4 cycles of pemetrexed carbo. I would be very reluctant to leave it until there is really a robust data to say that the osimertinib is giving us that much benefit that we don't need the chemo.
You know, the advantage we may have is in those patients with stage 3A disease that didn't recover very well from the surgery, that maybe are old population, maybe there it's a good option to skip the chemo and just do the adjuvant osimertinib. But I agree with you, adjuvant chemo has so established place that...
So the other point of it, Dr. Rosario, I would kind of worry that would it happen that some stage 3 patients in the trial, someone who just looked at it and said, oh, let's not give them chemo, anyway they're going to get osimertinib, and they ended up in the control arm. So the benefit was bigger. So it could be that if everyone got adjuvant chemo, the benefit would not have been that big. You can look at it both ways.
Yeah,
so
absolutely. Absolutely, completely agree. Yeah.
So Dr. Krishna Prasad, you start treatment with this because now it is FDA approved. It will soon get approved in India, I'm hoping, and then we'll start it. What will you do when your patient progresses?
At that point of time, we hope that doesn't happen. But when it happens, we need to rebiopsy it at that point of time, see whether what could be the reason for that, and treat accordingly, just like how you would do in any advanced disease.
So the reason I keep thinking is, are we, by doing adjuvant and using it early, are we changing some biology of the disease, or it's still going to be the same way as stage 4 behaves? I think it'll be a wonderful learning experience. A lot of new things are going to happen as we start doing this. But definitely we are giving a big benefit to our patients, and I kind of agree. It is practice changing. I think our time is up. So I think it's been wonderful discussing with all of you. I would put a provocative question to Dr. Rosario before I close. Would you extrapolate data for ALK and ROS in the adjuvant setting? I recently had a patient whom we operated and turned out ROS1 positive, and she's been operated completely.
No, to tell you the truth, no. I don't think this is the way to move forward. I think we need some more data. We are not going to have a phase 3 trial for ROS, it's clear, but we need some more strong data before doing that movement. But I think this trial, the DAURA trial, is helping to open the mind of not only physicians, but also the regulators. So probably with a small number or a small quantity of data, we can get approvals for this specific subset of ROS and TRAC or ALK positive non-small cell lung cancer patients. So I think we need to move forward trying to get some kind of good data before doing that. This is just a personal opinion.
Right. No, thank you very much. So thank you, everyone. It was wonderful discussing. It is wonderful having all the people who are involved in lung cancer management all together in one platform and have a discussion. Thank you, AstraZeneca, and over to you. Back.
Thank you, Amit. It was a wonderful panel. Pleasure to be a part of it. Thank you.
Thank you.
Thank you all. Yeah.
Thank you, Dr. Amit.
Thank you.
Great pleasure.
Some chat back questions are there. Actually.
Oh,
some few questions. I think some are there already answered. Yes.
Mm-hmm.
You're taking the questions, Dr. Satheesh?
Yes, like there are a few questions are there. The biomarker, I think they're already you asked actually in the panel discussions already done. Guidelines are like only like right now as per ADAURA, EGFR is there other tests are in the clinical trial, not in the day-to-day practice. That is already answered. And regarding this like stage, what is the incidence of EGFR mutation? Because there we are having data for a metastatic disease, advanced disease. Is there any data? Is there like early lung cancer stage by stage 1, stage 2, stage 3? And is there incidence of positivity in EGFR mutation?
There are some data. There are some retrospective data. It seems that it's around 16 to 20% in non-ASEAN population. Other reports from Asia around 30 to 40%. And we have collaborated with the ETOP, European Thoracic Oncology Group, and the incidence in early stages is around 5%. So it depends on the study you are analyzing, but I think it's more or less what we have seen in advanced stages. 10 to 15 in Caucasian is much higher in ASEAN population.
There's a very interesting question from Dr. Anil Kukreja. He's asking that if you, in the present COVID pandemic, we are doing low-dose CTs, we are doing CTs for everyone. Have we increased the incidence of diagnosis of lung cancer? I don't know, Dr. Satyanarayan, if you have seen an increase in lung cancer, if you're there?
Yes, I saw the question. That is a pretty intelligent question. Believe it or not, we've seen, stray few patients with the incidental mass, nodules, and things like that when they have had a CAT scan for the purpose of HRCT for the purpose of COVID. And unfortunately, I think most of them, majority, metastatic nodules, stage 4, straight away stage 4 kind of disease. And with the COVID, we would not do, any intervention till they are out of the hyperinflammatory phase.
Right. Thank you.
Thank you, sir. Thank you, Dr. Amit Rauthan. And I request Dr. Poonam Patil make expert comment on closing remarks.
Yeah, so we had an excellent session today. And it was a very good talk by Dr. Rosario first, and that Dr. Sarjana first, followed by Dr. Rosario, and both gave a good, concise direction to go ahead. And the panel discussion was also very interactive, and we all learned a lot from this. Thank you very much.